Hi guys, thanks for joining me on today's live. I'm so excited to have one of my dearest friends. She's also a fertility doctor in Florida, Dr. Jenna McCarthy. We've known each other for, we were talking this morning, 15 years. So between the two of us, we have a lot of IVF experience, and we're going to answer your questions today. And I got so many awesome questions. So we're going to start at 10, start joining, start chatting your questions. And then for those of you who don't know, I have a school. It's called the Egg Whisperer School. Class on Monday is the Tushy class on Fridays is the IVF class. So please join the class if you want to get some one-on-one, not necessarily one-on-one, but I will answer questions one-on-one, but it's a group class live setting. So you can also take the course, get some feedback as I kind of talk you through stuff as well. So let's see, there's Dr. McCarthy. Here she comes. Here's Jenna. With her. If you guys missed the show, she was on the show this week. So you should watch that Instagram live, the show that we did about IVF mistakes. Hi, Jenna.
How are you?
It's awesome to see you. So for our audience, for the folks that are watching right now who don't necessarily know you quite yet, you guys tell us about yourself, where you practice, and all that good stuff.
Oh, sure. So my name is Jenna McCarthy. I'm a board certified reproductive endocrinologist. My office is in Jupiter, Florida, which is just outside of West Palm Beach, for those of you who aren't familiar with Florida geography. I work for a company called IVFMD, and I've been there for, at this point, almost 10 years. So we kind of pride ourselves on individualized care for our patients. All of our offices tend to have a small number of docs so that when patients come in, they have that feeling that they're in a small boutique practice, but we have the resources of a large facility behind us. So from an embryology perspective, we have excellent success rates and are able to offer quite a bit to our patients.
Yeah, well, we had a lot of fun talking this week about the most common IVF mistakes. And between the two of us, there isn't anything we haven't seen, and we can certainly troubleshoot any problem that patients have. Some of the stories were great. So if you guys haven't watched that interview that I did with Jenna this week, you guys should watch it. Okay, well, we got a whole bunch of questions, and I want to be sure to get to all of them because I know people are going to be adding questions to our live Q&A right now as well. So here we go. So Dr. McCarthy, what type of pain control is there for egg retrievals?
Well, there's a couple. So first off, you have to think about it in two forms. There's the intraoperative pain control and the postoperative pain control. So intraop, many facilities will use propofol or a combination of a narcotic and maybe a medication like Versed, which is kind of a sedative. Postoperatively, again, depending on your doctor, they may offer you Tylenol, they may offer you IV NSAIDs like Toradol, they may offer you ibuprofen, or they may offer you a little bit of narcotic like Vicodin or something like that, depending on your pain level.
Yeah, where you and I trained, we were used to using a very light sedation. So Jenna and I can use our voices to put people to sleep. We have training in that. Okay, so when do you recommend acupuncture? Before and after retrieval and transfer?
So I encourage my patients to work with an acupuncturist from the beginning, potentially even leading into stimulation, definitely during stimulation. And then I like for them to use it during their frozen embryo transfer as well, and particularly around time of transfer, because I think that's where the data is strongest.
Right. And then what are the pros and cons of fresh transfer? What do you tell your patients?
Most of my cycles these days are direct to frozen for a couple of reasons. One, because many of my patients are electing to do pre-implantation genetic testing, and because it takes a little bit of time to get those test results back, that necessitates freezing the embryos while we wait for the results. Right. My higher risk patients, like women with PCOS, and also patients with endometriosis, benefit substantially from doing direct to frozen embryo transfer. And then that kind of leaves a smaller population for fresh embryo transfer. So we're not doing as many fresh transfers as we used to.
Yeah. And do you recommend CoQ10 for your patients?
I do. I feel like CoQ10 is one of the things that pretty much anybody can take. There's not ever been shown to be any harm to it. And I do think that there can be a benefit.
Yeah. And what's the difference, and I'm sure you get this question too, between ubiquinol and CoQ10? Does it matter which form they take?
One of them is just the activated form. So I tell them they can take whichever one they want and their body will activate it for them.
Absolutely. Okay, here's another question. What do you think about transferring 1 versus 2 cleavage stage embryos? And for those of you who don't know what a cleavage stage is, basically a day 3 embryo. So what would you counsel someone who asked that question?
So I don't do any day three embryo transfers anymore. However, you know, Amy, you remember we did a lot of those when we were at Michigan. And it really depends on your age, the number of cycles you've been through before, and the quality of your embryos, whether or not you want to do a single embryo transfer or a double embryo transfer. And that's really something, because it has to be personalized, should be discussed with your doctor.
Right. And then what about the use of birth control pills? When do you, and I call birth control pills fertility planning pills, because when we tell a patient that we're going to put them on birth control, they sometimes think that you're trying to prevent them from getting pregnant, and it's far from the truth. So at what point, how do you make that decision to use birth control?
So a lot of my patients will go on birth control pills. I use it to try and synchronize the follicles within the ovary, so that we don't end up with a single follicle coming up ahead of the rest of the group, because that can actually ruin a cycle. We also, in our Jupiter office, are doing a process called batching, where we're doing IVF for 2 weeks out of every month. And so most of my patients will take somewhere between 10 and 21 days worth of pills, whereas historically patients would take a pack of pills. So it's not that they're staying on pills longer, but we are still definitely using it to help them have a period at the time that we need them to, so that we can stimulate them with our batch.
Yeah. And for me, a lot of my patients are over 40. If your follicle count is under 10, sometimes I won't use them. But certainly if you have a count that's over 15, depending on your age and when you want the egg retrieval to fall, sometimes I use them. So that's how I do it. And just something funny, every time you say Jupiter office, I'm thinking, one day Jenna will have a Jupiter office because of SpaceX. My April Fool's joke was this year going to be, I did the Tesla testicular temperature tracking system, for those of you who don't know my April Fool's joke. But this year I was actually going to do that. I was chosen to do the first IVF cycle in space, but maybe you should do it next year.
That would have been awesome. Yeah, we actually got to see the launch yesterday. That was really cool.
Oh, that is cool. Okay, so here's a scenario that I got sent to us for today's Q&A. Here it goes. I'm doing an ERA mock cycle right now, and we'll also be doing a receptiva test. I have 4 PGS tested, excellent embryos, so that I can hopefully have 2 children with them. And I haven't tried a transfer yet. I've never had a positive pregnancy test, and I have a sinking feeling I have endometriosis, and this isn't going to work. My question is this: how can I prepare my body in the next 6 weeks with diet and supplements to get the best possible outcome for pregnancy? Should I completely cut out alcohol and caffeine? I'm not really seeing much research about this.
It's because it's not there. I mean, there isn't a lot of research on sort of what the best diet is for women going through IVF, or the best lifestyle changes. In general, it's all the things that we already know that can be so hard to implement. Maintain a normal weight, maintain a healthy diet. There is some small amount of data that suggests the Mediterranean diet may be the healthiest for women going through IVF, sort of high healthy fats. And in terms of nutritional supplements, once the embryos are already created, I don't know that there's a lot of nutritional supplements that have been shown to be beneficial in terms of helping with success with frozen embryo transfers. Most of the data has been looking at trying to create those normal embryos. And you've already done it, girl. So hopefully we're going to see some positives for you in your future.
Absolutely. A good prenatal vitamin with fish oil, meditation, decreasing stress. That's the best way that you can decrease inflammation in your body that's in your control and having a healthy weight. I totally agree. Okay. Here's another question. My doctor prescribed 100 milligrams suppositories of progesterone taken before bed for my upcoming IUI. I have PCOS, trying to conceive for 4 years. This is my second IUI, 7th month of treatment. I heard you talk about progesterone 3 times a day with a strict dose timing. How many milligrams do you suggest, and how can I talk to my doctor about upping my dose?
Well, since you're doing an IUI cycle, you're ovulating on your own. So your body is going to be making most of the progesterone. And so unlike an IVF cycle, a frozen embryo transfer cycle in particular, where women aren't making any progesterone, you've already got this covered. We're just adding a little bit extra, a little boost.
Yeah, a little something, a little extra water for that marathon run. You don't need it 3 times a day. Okay. Is there any med that can help with ovarian reserve? And I know you probably hear this daily because, of course, when we're running out of eggs, we want to grow more eggs. So what do you tell your patients?
Well, so I actually like the book. It starts with the egg. And many of the supplements in that I will offer to patients if they want to. I do warn them that the data is limited. And so if they're not reacting well to a nutritional supplement, or if they simply don't want to take them, I don't think that they're doing anything wrong by choosing not to. But there are a number of supplements that may provide benefit. And you had mentioned CoQ10, for example.
Right. Okay. If someone were to just come to you, Jenna, and say, how do I figure out when I'm ovulating? What's like a quick and easy thing you would tell them in 10 seconds or less? I'm just kidding.
I love OPKs.
There you go. I love OPKs. That's 3 words.
Yep, exactly.
Yeah.
I find they're the easiest way to know. And sometimes the first month you have to use them, starting from the day you stop bleeding until the day you finally get a positive. And depending on you, that could be a week, that could be 3 weeks. But it definitely will make a difference. And then from that point on, you can kind of tailor it.
Right. Or another quick thing, if let's say someone lives in a country that doesn't have access to OPKs, you can
Hmm.
take the period date, take the length of your cycle, subtract 10 and then 14 and have
Hmm.
sex in that window. And you
Yep.
usually won't miss
Yep.
ovulation. Okay,
Yep.
here we go. We got a lot of questions on PCOS, so I'm just going to lump
Mhm.
them all together. Can you talk a little bit more about PCOS and what are some signs or early signs of the syndrome?
So PCOS clinically is defined as having two out of the following three criteria. The first is irregular menstrual cycles, and that can fall into a whole range. That can be I don't get periods very often. It could be I get a period every 2 weeks. The second category are what we call signs of elevated testosterone. Either you have a blood test that shows that, or you have acne. Little known fact, adult women aren't really supposed to be getting a lot of acne. Unwanted hair growth, especially like on your face or on
Mm-hmm.
your chest, places that we're most likely to pluck or wax or laser. And then the final one is a specific appearance of the ovaries on ultrasound. So that's the only one you can't figure out for yourself ahead of time.
Mm-hmm.
And then there are other characteristics that go along with PCOS, like having problems losing weight, finding it very easy to gain weight, maybe having insulin resistance. Those aren't the actual criteria that tell you that you have it, but those can be other signs that maybe you should talk with your doctor.
Yeah. Also depression. Some patients have problems with
Absolutely.
depression as well.
Yeah.
Okay. And then are there certain OPKs that you recommend for your PCOS patients that you think work better than others?
I like the clear blue because it has a higher threshold for the LH level. So LH is the hormone that's measured in OPKs, and women with PCOS can have high baseline levels of LH. And
Mm-hmm.
the way you know if that's you is if you buy the cheapo test and you use it the day, like while you're still bleeding, and it's positive, you're not ovulating. And
Yeah.
you probably can't use that test to tell whether or not, basically that test wouldn't work for you.
Right. I also like the proof test. So it's a test that looks at
Mm-hmm.
a metabolite of progesterone in the urine. So for women who have a positive LH surge, especially with PCOS, like you said, it could be a false positive. Then you can check with the proof test a few days later to see if it's detecting that metabolite to confirm ovulation. Okay. So is PCOS reversible with diet and exercise?
The symptoms of PCOS are reversible. I argue that having PCOS is like having brown eyes. I can cover them up with contact lenses and make them look blue, but I'm not going to change that underlying predisposition. However, the symptoms are really what we care about, right? When we're trying to have a baby, we want regular cycles so we know when to have sex. We want to stop having acne on our faces and hair growing. And so weight loss has been shown to be effective in that. A combination of about a 10% weight loss, and which is, people think, oh my goodness, I have to weigh 120 pounds. No, you don't. 10% weight loss, and add in some regular exercise, 30 minutes a day, and we can see the symptoms go down. Some women, many women, will begin getting regular cycles, and that's really what we're looking for from a fertility perspective.
Yeah. I know. I think a lot of our patients get some sort of feedback from somewhere that as soon as you're starting to or wanting to try to get pregnant, you should stop exercising. And I have patients that say that I decided I want to try and get pregnant, so I stopped exercising. And I'm like,
Mm-hmm.
who told you that? And it's like, oh,
Right.
I read it online that exercise isn't good. And I'm like,
Mm-hmm.
that's not true. Okay. So I'm glad you addressed that. Here's another clinical scenario question. Hi, doctors. I'm day 8 of IVF injections, day 18 of my period cycle as I've been on birth control pills for a week. My egg retrieval is possibly Thursday, June 4th. I just realized that I'm having egg white discharge. Am I ovulating? Does that affect the retrieval? Should I worry?
I get this question all the time. So first off, congratulations and good luck with your retrieval on the 4th. The egg white mucus in a woman who's experiencing a natural spontaneous ovulation cycle goes along with ovulation because that's the point where the estrogen level gets high enough to create that cervical mucus. In an IVF cycle, you can start getting that mucus on like day 6 of stimulation because your estrogen level is high. So it's just a sign of high estrogen. It's not actually a sign of ovulation.
Exactly. Okay, here's another scenario. I conceived naturally and then had a miscarriage at 9 weeks. The pregnancy did have a chromosomal issue. I've been trying to conceive naturally for 9 months now with no luck and have moved to IVF. I'm 30 years old and apart from a slightly raised CA-125 level, which my specialist says may be linked to endometriosis, my infertility is unexplained. I have 5 PGS normal blasts, all high quality. If my first transfer doesn't work, do you think I should have a laparoscopy to confirm that I don't have endometriosis or just keep trying with another frozen embryo transfer?
I usually don't encourage going backwards to laparoscopy. The data seems to suggest that laparoscopy works best for women with early stage endometriosis who are then going to try using simple methods. IVF has such high success rates. That being said, you may, if your first transfer isn't successful, you may want to consider doing an ERA or a Receptiva or both. because endometriosis can impact implantation, and that can be corrected with altering progesterone protocols. So it might be worthwhile to see which one works for you. But since about 80% of women, we've already got the right protocol. That's how, I mean, this is years and years worth of trying to figure out what the best protocol for women is. We don't want necessarily everybody to do the ERA and Receptiva because most of them aren't going to need it.
Absolutely. And so there are medical management options as well before going to laparoscopy too. And without more diagnostic testing, you may not have all the information you need to make the best decision for yourself just based off of a CA 125, because those levels can fluctuate too, even in a menstrual cycle.
And definitely if it was taken post-retrieval, the retrieval itself could have done it.
Okay. Hi, doctors. I would like to get your opinion on what my next steps should be. I've done 2 rounds of egg retrievals with no normal embryos. It seems that I have a lot of eggs though.
Yeah, that's always tough because there's so many variables. Things that I would need to know to be able to answer your question specifically. Does your husband have severe male factor? We know that that can contribute to an increased rate of abnormal embryos when you're doing genetic testing. How old are you? What was the quality of the embryos that were biopsied? So there's really a lot. So this is something where unfortunately I can't give you a great answer today, and I'm going to encourage you to talk about it more with your doctor.
So what if she's 40 years old? What would you tell her in that scenario?
Well, unfortunately, if she's 40 years old with no other, no severe male factor or anything like that, history of chemo, it's most likely related to egg quality. And so time is not on our side. And so she may want to consider doing additional cycles quickly with modified protocols. If she's over 43, 44, as much as I hate to say it, she may want to start considering donor egg, because we know that women, most of our patients, this, Amy, they wanted to have a baby 3 years ago, and they don't want to spend $100,000 on IVF to then be told you need to have donor eggs. So I do try to bring that discussion in earlier, and this is basically the point where I would start talking about it with someone. They certainly 100% have the right to say, no, I want to try something different. But I do think that this is a point in somebody, past their 43rd birthday where I would be having a definite conversation about, do we want to look at another avenue of building your family?
Right. You and I want our patients to be parents, not patients. Right?
Exactly. Yes.
And I think what's so hard is women who are 40, especially because we're taking such good care of ourselves right now and everyone looks 30, we feel like we should be fertile and we feel like there's something wrong with us. So for women out there who are watching this and you're 40 and not having normal blasts, you're normal. There's nothing wrong with you. And I think that message isn't out there quite enough. Here's another question. I had my first child with IVF and want to know if you have any tips or if you know anything natural I can do to get pregnant.
Well, we know that about 25% of women who go through IVF will conceive spontaneously. So, I'll send that out for you. I hope that you're going to be one of that 25%. Other than that, all of the things that you already know, unfortunately, maintain that healthy weight, regular exercise, timing intercourse. You can also check back in with your IVF doctor and make sure that things are optimized, like, for example, your thyroid, your prolactin level. Make sure that there's nothing that happened with the uterus as a result of the pregnancy. For example, taking a look at the C-section scar, make sure that that looks like it healed well, making sure that there's no scar tissue or development of polyps or fibroids or anything inside the uterus since your last baby was born. So I usually advocate for a check-in, and then if you want to try on your own, my goodness, go for it.
Right, exactly. Another thing I do, if you're someone who got pregnant with IVF and your husband's sperm was really low, or you got pregnant naturally and your husband's sperm was really low, maybe freeze that sperm so that the next time you're going back to do IVF or IUI in 2 or 3 years, you're using that younger sperm. My bias is always younger sperm. Okay. Is there a possibility of getting pregnant naturally with low egg reserve?
Absolutely. So one of the things that I think it's important for patients to hear is that AMH, which is one of the markers that we use for ovarian reserve, is not a good predictor of spontaneous pregnancy rates. And I say this over and over again. It's a good predictor of the number of eggs you get if you do IVF with a maximal stimulation. And we know that the more eggs you get with IVF, usually the greater your chance of success. But when your body is forcing the eggs to compete against each other each month, and in theory, the best one is winning, whether you have 1 egg or 3 eggs, it just takes the golden one to be coming up, and then you'll be pregnant.
I feel like we are mirroring each other. I say the exact same thing, literally in those words. Okay, here's another scenario. I did endometriosis surgery to have a successful transfer for my first baby, and I also did the ERA test. Should I do the ERA test again for my second transfer? And what about doing the Receptiva again? Should I do that again and maybe plan surgery for my next successful transfer? What would you tell somebody?
So I just want to make sure that I'm understanding this correctly. You believe that she had the laparoscopy first, then the ERA, then the transfer, and has successfully had a baby?
Right. She did ERA receptiva, found endometriosis, did the laparoscopy, had a baby. And now she's asking, she's ready for baby number two. Should she go back and do all those things again, or should she just go right into a transfer?
She could do either. If the situation was that she had the receptiva, did the laparoscopy, and was now wondering, should she repeat the receptiva and the ERA before a transfer? I would say absolutely. If you've had surgery since your last ERA, I would say go ahead and do the test again.
Mm-hmm.
I don't usually make people repeat an ERA if they had a successful pregnancy. And I don't know what your thoughts are, Amy. I know that can be a little bit controversial.
I repeat it if, let's say, the window was off the first time and really off. So let's say my average number of hours is 130 or so. And let's say her window was 111 hours. And then we got pregnant and had a baby. Sometimes I'll repeat it to make sure it's still like that, because that's a little bit of a shorter window than I'm used to. Okay, here's another question. I'm planning IUI in a couple months, and I have a question. Since my period is very light and lasts up to 2 days heavy bleeding, 3 days spotting, does this mean my ovulation will start sooner? And is my ovulation earlier? Does my period flow determine when I ovulate?
Not usually, no. Cycle length is a better predictor of ovulation, like you had already mentioned. Subtracting 10 to 14 days from from the length of your cycle usually gives you a better idea of when you're ovulating than the actual number of days of flow.
Okay. Doctors, my periods are sometimes 24 days, sometimes 28 days, sometimes 32 days, usually ovulation around 16 to 18 days. Are these cycle variations because there's something wrong with me?
I think it sounds like you might be having a little bit of ovulatory dysfunction. Now, that doesn't mean there's something wrong with you, but it just means we may be able to optimize things for you. So when you see that your cycle length varies, but your ovulation is staying stable, it suggests usually a luteal phase defect, that you're maybe not ovulating as well as you could every month. And that's something that we can usually correct pretty easily. So you may want to talk with someone about that.
Great. This is an IVF protocol question. If you have a patient who has a high FSH level going into IVF, would you still use birth control pills for them?
I usually don't. If I have someone where we have really significant decreased ovarian reserve, I'll frequently look at either a luteal estrase protocol or a protocol without any hormonal preamble. I can't think of the word I'm looking for.
Got it.
Basically,
Priming.
no hormones.
No priming. No priming.
Exactly.
None of this priming business. Okay,
right.
Great. Exactly. So we went through all the questions that were sent to me as direct message and emailed, and now I'm going to go through all the questions that people have been asking live. How accurate are ovulation tests?
They're pretty accurate. Basically, what they're measuring is when your LH level reaches a certain point, and for the average woman, that's going to be indicative of ovulation. They're not perfect, and certainly women with PCOS are going to be one of the ones who get the highest rate of false positives. One thing I'll tell patients to do is, if they're not sure, recheck it the next day, because your LH surge usually lasts for 2 days. So if it's positive 2 days in a row, then yeah, that's probably real. If it was positive at night and negative again the next morning, that's more likely to have been a false positive. But have sex anyway, just in case.
Exactly. Here's the question. I'm 37. My AMH is 1.7 with male factor infertility. I did ICSI. Out of 5 eggs, only 1 fertilized. All my previous rounds were similar. Should I think about egg donation?
You may want to think about sperm donation if we're dealing with a male factor issue. It could just be that the sperm that is available isn't good enough to fertilize the eggs, even with the assistance of ICSI. Because remember, ICSI is the magician that gets the knight over the moat, past the dragon, and into the castle, right? It still has to kiss the princess and wake her up all by itself. The magician can't help with that part. Exactly.
I love it. That's great. That's a great analogy. And I feel as women, we give up our own DNA so much faster and earlier than men to satisfy, because we're so worried about them and their egos. And while it's hard for all of us, it does make sense to consider sperm donor in that type of situation potentially. Okay, here's another question. What's the difference between, actually, I'm going to go to this question. Can I drink coffee during either fertility treatment or after a transfer? What do you tell your patients?
I may be a little bit more lenient than the average IVF doctor. I know that many of my partners say absolutely no caffeine during their cycle. Yeah. The American College of OBGYNs say up to 2 cups per day while pregnant. And so I kind of go a little bit lower than that just as a safety. And I tell my patients, listen, if you want to have 1 cup a day, that's fine. Definitely keeps the caffeine headache away. If they can go to half caff, that's great too. And then they can have a cup and without feeling concerned at all.
Yeah. What do you tell patients in your lab as far as which embryos are better, day 5 or day 6? And is there a big difference for you guys?
Well, for us, as well as I think nationally, what we've seen is that embryos that are ready on day 5 tend to be the highest quality embryos. So it's not the day per se, it's really a reflection of the embryo. If the embryo is able to grow quickly and provide a high quality embryo by day 5, that's usually a higher quality embryo than an embryo that took that extra day. That being said, we've got excellent success rates with day 6. So I tell patients not to
Yeah.
stress if
Yeah.
the embryo wasn't frozen till day 6. And even day 7 these days, people have good success rates on euploid. We do test all day 7s.
Mm-hmm.
So euploid day 7 embryos.
Excellent. That's great to hear. Is it harder to get good quality embryos or harder to get pregnant with those good quality embryos? That's a hard question. I don't know that.
I think it depends on the scenario, to be
Yeah.
perfectly honest with you.
Yeah.
Yeah.
Yeah. Can you walk us through what happens to in the lab from egg retrieval to transfer? And let's just talk about a fresh embryo a frozen embryo transfer in your lab. From egg retrieval to transfer, what happens in the lab?
Okay, so I hand off the eggs to the embryology team, usually around the same time that her husband or partner is providing a sperm sample or they're thawing the donor sperm sample. If we're doing a process called ICSI, the eggs then rest for a few hours to finish their final maturing in the dish. And then the cumulus cells, which are the nurse cells that surround each egg and keep them healthy, those are stripped off so they can basically reveal the naked egg, if you will. And then they inject one sperm into each
A
egg.
lot of stripping and naked.
There's a lot
Okay.
of stripping,
Stripping and
exactly.
naked. Yeah.
If we're doing conventional insemination, simply the embryologist will lay the sperm on top of the egg. And then they're placed in the incubator. We use a continuous video monitoring for our embryo culture systems, and the embryos. So basically, the embryos remain in the incubator untouched for until they're ready to be frozen, whether that's day 5, day 6, or day 7. They're checked at regular intervals. So we check on day 1 to look at what our fertilization rate was, and we give that information to the patient because we think it's important. We know they're home stressing. But what we don't do is we don't call them every single day. And that was based off of patient feedback. What we were finding was that patients were getting really stressed out because if you start with 10 embryos, 10 normal fertilizations, on average, you're going to get 4, maybe 5 blastocysts. And to get a call every day in the afternoon, the way we did in fellowship, hey, you've got one less embryo that's growing. That gets really stressful. Whereas if you're told from the beginning, hey, expect, somewhere between 3 and 5, we think that this will be okay. When you get that call, hey, you got 4, you feel successful. And I think that's important. Once the embryos reach the blastocyst stage, they're either biopsied, if that's what the couple has chosen. And with our biopsy, we're using a laser and removing a couple cells from the portion of the embryo that will ultimately make the placenta. The part of the embryo that will make the baby is never touched. And then the embryos are frozen. They naturally contract at the time of the biopsy. And so that's actually a very safe time to freeze them because they're contracted down. They have as little fluid in them as possible. And we don't want lots of water in our embryos because that can make crystals that damage them. And then once they're frozen, they hang out while we wait for testing results or the frozen embryo transfer.
Awesome. Okay, so my husband has 16 million sperm, 0% motile, 100% abnormal forms. Would you do PGT in that scenario?
Depends on the woman's age, if you really want to know the truth. If you're 30 years old and then it doesn't seem to have a huge difference, you could definitely argue for it. I never tell a couple or a woman that she can't have PGT. What I talk with them about more is this IVF add-on that costs X amount of money going to substantially improve your chances of success? And if the answer to that is probably not, then I encourage them to think about doing their cycle without. If she's 40 years old, then absolutely, we definitely would be advocating for PGT because she's going to have a much higher success rate because it'll allow us to identify which embryos are the normal ones.
Great. I have PCOS and my TSH jumped from 10 to 0.09. Is IUI out of the question just this month? I just finished my letrozole. Should I try?
Her say that again?
Her TSH, it went from 10. Actually, it went down, but her thyroid function jumped. You know what I mean? 10 to 0.01.
0.01. So she's a little bit hyperthyroid now probably a little bit over replaced on her Synthroid. I offer my patients the option of, certainly I would say try to get pregnant this month because hyperthyroidism is less harmful, especially when it's due to over replacement. You can kind of back off a little bit on the medication. If a patient was starting a frozen embryo transfer cycle, I would absolutely ask them to wait till we've got things optimized.
Right. Okay, here's another question. Do you find that egg quality is impaired with PCOS even if the patient is young?
Yeah, unfortunately, I do. What I tell patients usually is that we think that women with PCOS have the same number of normal eggs as everybody else, but they've got a lot more noise because they have so
Hmm.
many other eggs. And so what we'll find is we still get great cycles from women with PCOS, but if we're looking at it from a percentage standpoint instead of a total number standpoint,
Hmm. I think Jenna's
40 eggs.
freezing. She just
Oh
froze
dear.
for 1 second. I'm sure she'll come back. She's coming back. There she is. Hi, Jenna. Hey,
Okay,
there you are.
sorry. I don't know
No,
what I
that was
did.
great. No, you did great. So we'll just go to the next question. So this is an IVF with sperm donor question. What's the best advice to give when choosing the type of vial for the cycle that you're doing?
We usually advocate using the ICI vials because we tend to get more sperm for less money.
Oh, nice. I do the
Yeah.
same thing. I kind of feel bad for the lab because they have to do more as far as processing, but that makes sense.
It's also fresh processing, so that's kind of
Yeah.
nice. It's not process and then freeze.
Yeah, nice. Okay. Are there certain forms of folic acid and vitamin E that you recommend in preparation for IVF?
For folic acid, I like L-methylfolate.
Yeah.
Basically, that's just the activated form of folic acid. So if a woman happens to have an MTHFR mutation, it doesn't matter because we're bypassing
Yeah.
it. I
Yeah.
haven't made any specific recommendations about vitamin E. How about you?
Not necessarily vitamin E unless they have a thin lining,
Yeah.
and it's in prenatals anyways. But for folate, I,
Hmm.
I agree. I'm right there with you. So you've recommended melatonin before, and that's probably just talking to me. Can you give
Yep,
more details when and how much or for how long? Is melatonin something that you recommend as well
it
for your
is.
low? Yeah,
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 I mean, I think there's two things about it. One, getting adequate sleep is important. And I think that that's probably helpful from a fertility standpoint. We know that people who work graveyard shifts and physicians and residents tend to have impaired fertility. And so I think that not getting enough sleep is probably a big deal. But there's also some data that suggests that it may actually benefit the eggs directly. So I usually tell patients 3 to 5 milligrams at bedtime.
yeah. So for a patient who's doing an IUI cycle and they have a positive OPK, do you still give the trigger shot?
Yes, I do. We do it as a backup.
Yeah, yeah,
Yeah,
I agree. It just helps with hormones and all that good stuff. It can increase your progesterone level. It doesn't hurt at all.
exactly.
What supplements should I be taking going into a frozen IVF transfer? I'm 37.
If you haven't had any lining issues in the past, I don't know that there's any supplements other than your prenatal vitamin that have been
Okay,
shown to make a difference.
yeah, okay, let's keep going. Let's see here. Why do IUIs have such a low success rate? I've done 5 and they all failed, and I'm turning 35. Should I move to IVF? Or actually, I'm moving to IVF. What suggestions do you have? Why did they all fail?
Right. So I think that's a great question. And I think what it speaks to is when we all did health class in high school, they told us all about how, it's so easy to get pregnant. Don't get near that thing, right?
Right.
But the reality is that humans actually have per month, humans have a pretty low pregnancy rate. So we're looking at ideal scenario. So that's two 16-year-olds having sex in the back of dad's Chevy, 15 to 20% chance per month. What we're
Good.
good at is cumulative pregnancy rates. Those same two 16-year-olds, if they keep having sex every month, they're looking at the 6 month mark, 80% of them are pregnant. By the 1 year mark, 90% are pregnant. And by the 2 year mark, 95% are pregnant.
Mhm.
Now, add that to the fact that, a woman at age 35, unfortunately, is going to have lower per cycle fertility than a 16-year-old. And typically, IUIs, you can expect to get somewhere between 15 and 20% pregnancy rate. Cumulative pregnancy rates usually top out somewhere between a third and half of patients who do IUIs will be successful after 3 to 4 IUIs. So I agree with what you're doing. If you've done five IUIs and you've had good responses and you're not pregnant, it is absolutely time to move to IVF.
Absolutely. And my golden rules are if you're 32 years old, you want 2 kids, maybe consider egg freezing before you do your
Mm-hmm.
IUIs potentially. Or if you're 37 and you already have 1 kid and you want a second, maybe just go right to IVF and skip IUI.
Yep.
Here's another question. Is brown spotting 4 to 6 days before my period every month a concern for my fertility?
Not necessarily. It could be a sign of endometriosis. That's a very, very soft marker, but it is one of the things that kind of makes me start asking additional questions to see whether or not you could have endometriosis. It could be suggestive.
Jenna's just breaking up just a little bit. And there she is. Go for it. You're back.
Sorry about that.
No
It
problem.
can it could be a sign of a luteal phase defect, which is a suboptimal ovulation, but it doesn't necessarily mean that you're not going to get pregnant.
Right. Okay. 33-year-old couple, AMH 0.85, antral follicle count 8. Would you use DHEA for diminished ovarian reserve?
So DHEA in some of the initial studies was very promising. I do still continue to use it. However, I warn patients that it can have some side effects. It can increase acne. Some women just don't feel well on it. And there is data that is showing, although we get a higher number of eggs when we do IVF with that, it may not translate to a higher number of embryos or a higher pregnancy rate. And so it's very much a personal choice. I don't think it's harming. I'm not 100% sure how well it's helping.
Right. So here's, we're going to close off the questions. It looks like we've done a really good job answering almost all of them, but we're getting close to the end today. So thank you, Jenna, for your time today. So here's the question, and I get this one all the time too. What do you tell your patients if they ask this question? You've just done the transfer and they say to you, what else can I do to increase my chances?
So the hardest thing is just hanging in there, to be perfectly honest. Spending time, we do a modified bed rest for 2 days. I don't want patients on strict bed rest. I just want them to be able to take it easy and not have to run out and do laundry and groceries and work. And so we have them take those 2 days off. And I just want them to be able to relax and be mellow. Now, I recognize they're going to be worried about this. They're going to be stressed about this. I don't want to make anyone more stressed out because they're stressing that they're stressing, right? That's not it at all. I just want to try to alter their environment as much as I can so that they can be as relaxed as possible in this particular scenario.
Awesome. Well, Jenna, thank you for this rapid fire, quick answering of all these questions. It was so fun to see you. You guys, I've known Jenna for 15 years. We went to fellowship together. And she practices, tell us where you practice.
I practice in Jupiter, Florida.
Yeah, so those of you who are in Florida or close to Florida, do you have patients that come from Alabama or any surrounding states as well to see you?
No, but we do have a lot of international patients.
Okay, great. Awesome. Yeah. Well, thank you, Jenna, for joining us on this Sunday. And for anyone who's watching who wants to join the Egg Whisperer School, I have a Tushy class on Monday and an IVF class on Friday. So please go to eggwhisperschool.com and be sure to sign up, and I'll see you there tomorrow. Okay, thanks, Jenna. Have a
Bye,
great
Amy.
day.
Thank you.
Bye-bye.
Take care.
Thank you, everybody. See you next time.